and working with NHS England for North West London and part of the transformation team, but also with Health Education North West London. There lies an important point, trying to bring together workforce transformation and the educational response. Now, we're all working in North West London, and a crucial part of our work relates to the way in which our 8 boroughs that make up North West London, our 8 CCGs, our provider NHS mental health, acute and foundation trusts and community trusts and higher education institutions came together to form a whole systems model of transformation surrounding and wrapping care around the patient, the user, and the general practice, which we find is the fulcrum of care coordination. I think it's very important that we recognise that a whole systems approach is absolutely crucial if we're going to change our workforce approach to population health. So above our whole systems model was a major restructuring of the acute sector in North West London. And you'll be very familiar with services across London in your own areas, for those of you who work in the city, where we've looked at urgent care pathways, we've looked at trauma care pathways, and we've looked at the role that community hospitals and step-down facilities can provide in a new regional configuration. That together has created new opportunities for community care, working with primary care and patient groups and the voluntary sector to start to provide new solutions while still having the benefit of expert regional structures with our high-tech hospitals such as Imperial, Chelsea Westminster, Brompton, and of course the Royal Marsden and North West London hospitals, Hillingdon, Ealing and West Middlesex. So all of those together forming a whole structure for individual patient transfer, but ensuring that we can work together to provide that whole systems care. So by working from that hospital reconfiguration programme, we brought people together. We networked and asked real questions about what would make a difference to provide excellent care closer to home. And what we discovered was very simple solutions, and our solution focused on local population health wrapped around the general practice, ensuring that the workforce could start to drive new ways of working, and that meant a real redesign of our community nursing workforce, our primary care workforce, and looking at new roles and ways of working underpinned by transformational principles, and driving the whole of this through a system of a helix of self-management, which of course you'll appreciate is crucial. So community capital was a major part of our work, unlocking the potential that individuals, their carers and their communities can bring to work in partnership with the professional response that transcends the health and social care sectors, and for those 3% of the population that present with major longer-term conditions, usually over 75 or 85, with risk stratifications at a high level, those people all have a multidisciplinary care plan now in North West London, wrapped around the general practice, which identifies the care solutions moving forward. So we're committed to a 3 to 5 year whole strategy for the whole systems integrated care strategy, and that shared vision is now being adopted across all aspects of health and social care and voluntary sector. Our steering group for our whole systems integrated care programme is made up of a representative of every organisation who is a stakeholder in North West London. So if you could imagine, this room would be filled and filled again with our steering group. That's exactly how we work. It's to share, to network and to develop that integrated solution close to the point of delivery. And our 3 principles are people empowered to direct their care, secondly GPs and their practice teams who are at the centre of organising and coordinating care, and our systems will enable and not hinder the provision of integrated care. A big call, a big ask, so IT systems having to be reviewed to talk to each other across boundaries, referral systems to work smoothly, discharge to be effective, and above all, our roles to be re-examined on the basis of competence and transformation, but still retaining the best of titles to protect the public, but ensuring we've got a flexible system. We have new hubs in primary care and we're progressing with co-commissioning across each of our 8 boroughs. Each borough will have a network of GPs, some of them moving into federations, some of them beginning to talk about employing specialist nurses in diabetes, COPD, bridging between the secondary care sector and our general practice. We've got over 50 new care coordinators or care navigators at Band 4 or Band 5, all being trained to work with GPs and our professional colleagues, and most importantly users, to help them navigate their way through the myriad of care responses and pathways. We recognise that workforce is a key enabler for all aspects of transformation, and hence we're developing new workforce solutions and new programmes of education to support individuals, much of which, or many of which, will be workforce delivered and linked through action learning to the workplace itself, crossing agencies and providing robust outcomes that will meet new professional standards that are being developed by Health Education England and by the QNI and other organisations for community nursing and general practice. No time to go through these particular examples, but you can have a read of those whilst I hand over to my colleague Sally, who will advise further on the work she's been undertaking in general practice.
Okay, for those who don't know me, I'm Sally Armstrong, a practice nurse in Ealing, and I've been involved with Health Education North West London to look at new ways of bringing new nurses into practice nursing, into primary care. And obviously you have certain barriers for nurses coming into primary care. You don't learn the skills in your general practice, in your general training that you necessarily need for primary care. So there are lots of new skills that you need to use. Also, sorry, can you hear me? Okay. Also, there I was going to say. There are barriers such as how do you transition from doing one job, you're a sister in ITU, you now want to be a practice nurse. How do you actually move from one area to the other? How do you know you actually want to do practice nursing? It may be something you want to dip your hands into you actually don't like. So we try to develop a programme to build really good foundations and then to train new nurses. And my colleague over here, Rachel Orton, manages this project. So what we've done so far is we've managed to recruit 30 practice nurses to train to be mentors, so that we have that in the workforce in across North West London, where nurses can come into practice and there's a qualified mentor there to train and supervise them. They are also going to then be available, I'm sure you're all aware of the care certificate coming into force at the end of the year, so they will be able to supervise HCAs to undertake the care certificate, and they will also be able to supervise training of new mentors, so it's a win-win. Why do we need to do this? Well, as part of Shaping a Healthier Future and all the numbers that were produced as a result of that, Henwell will want to recruit 80% more practice nurses. And I'm not sure, actually, I haven't asked that dreaded question, does that include filling the gaps for all those nurses that are actually going to be retiring as well? Because as you know, practice nursing, most practice nurses are over 50 and won't be in the profession for that long. So the project that we're doing at the moment is we're going to recruit 30 nurses. We've already recruited 31. Oh, wow. We've gone over that. So there are a certain number of nurses who at the moment are undertaking an LMC course, which is part online and also has 2 face-to-face study days. There are also the SMEAR, ZIMS and ear care courses, which are done in separate modules so that they learn the basic skills of practice nursing. And they also come into practices to complete certain competencies and obviously to get that experience. And most of them, in fact probably all of them, are doing this whilst they're still doing their job. So it's quite difficult, it's quite tough. To date, we've trained 13 mentors, 7 underway. We've got 9 trainees in practice. The majority, as I just said, are still doing their job, and some have actually been offered practice nursing posts as well. Just to add on to that, there are several other initiatives, because obviously training new nurses is all well and good, but you've also got to keep upskilling your existing workforce, keep encouraging them to progress through the career pathway to do their prescribing, nurse practitioner, etc. So we've got lots of CPPD incentives going on. We've also introduced an IT toolkit for appraisal and revalidation, which I know lots of other areas have done as well. And we have what's called an incentives package, which I don't know, my colleague's not here, Lizzie Woolman, whose ingenious idea this was. So a lot of practices are very reluctant to let their nurses go on long-term courses because it costs them. They still have to pay for that nurse's time. So this is an incentive funded by Henwell, where if they complete the course, the practice then gets the money back that it costs for their time to be away. So they are actually getting reimbursed their backfill effectively. So it's an incentive for the practices. And that's...
What we're going to look at is a new approach to supporting our student nurses and getting them to have that important exposure to community nursing. So it is an innovative approach to education. Currently, all student nurses will do one placement in the community. Some universities vary and are able to offer more than one placement. If they are lucky, they will do 8 weeks with a district nurse. If they're not so lucky, it could be 4 weeks in a sexual health clinic, and that is their total exposure to community nursing. So it is important that actually we need to redress that balance because of the opportunities, the experience, and as also to looking to recruit them in the future, that they gain a wider perspective as possible. All right, okay. If we go to the next one. So, why should we encourage the growth of student nurse placements within the community? If they don't have that exposure, how can they know that it's important to come to us, that the opportunities are out there for them? It is important that we have highly skilled staff with both the right professional and clinical skills, along with the right compassion, kindness and respect for our patients. Excellent care is about people and personal relationships, not solely about the organisation and its processes. And the excellent care and support for our patients is underpinned by a human connection between people requiring care and their families. And already from the first group of students that we've had through, we are starting to see that they are not just having what you would call the traditional skills. They are starting to develop their compassion, their care. They're very motivated about the care that they are delivering for the patients. Hope we come to the next slide. So, what is it that we need to do? So in order to ensure that students are fit for registration in a changing healthcare landscape, it is vital that we increase the opportunity for students to understand and gain that community experience, and for them to then consider post-registration opportunities within the community environment. So what are we going to do about it? Currently we have a pilot, and we are working in partnership with the Florence Nightingale Faculty of Nursing and Midwifery at King's College London. We are developing and implementing and evaluating a placement circuit for our BSc adult nursing students, which hopefully will prepare them for registration, but more importantly, will have an emphasis on out-of-hospital community placements. We're not going to ignore the acute completely, so they will do 1 acute placement per year. So that will be 3 acute placements, and we are hoping that will be a medical surgical and a more high dependency placement. The aim of working with these students is that we'll focus on out-of-hospital care, community and primary care, and they will meet the NMC competencies at the end of that to be a registered nurse. Already one of the questions we've had is, will they be a nurse? Yes, they will, and they will go on the register. Also, what we want to do is that on successful completion, we want to try and attract these students to come and work with us, yes, at CLCH, but in a wider sense into a community setting. So we are in our first phases of our pilot. Feedback from the students has been very positive, and it's really encouraging to see them grow. And I'll hand over to Darren.
Okay, thank you, Tracy. So, how does this project fit in with our career model development? One of the things we were keen to do as an organisation was to make sure we have a career basically development pathway in place. And obviously from a pre-registration perspective, the pilot that's currently underway is very important as part of that. Secondly, we wanted students to know that when they come to work for us, they do have a competencies-based assessment process as part of that career development, which will support them in their career development, and then ultimately take them forward to their actual career development, maybe outside of that area, but for them to be able to recognise there are career opportunities within primary care and community services. So what do we see as some of the future potential opportunities? I mean, the rotational posts between general practice, practice nursing and the acute care providers is something we're keen to develop further as part of this placement pilot, and also to replicate it across other professional areas other than just nursing. And obviously what we want to do is help basically patients transition from the community, from the hospital into the community, and that people around that sort of transition have a better understanding of the patient journey. So these pictures that were up at the beginning, sorry, put the next slide up. These were actually taken from the 1949 handbook of district nursing, which is a fascinating read. And I must say, things haven't really changed when you read that book. There's still a lot of chapters around the importance of data collection and letting commissioners know what you're doing. But ultimately, we're trying to raise the profile of community nursing to say it's not about delivering babies, it's not about riding around on a bike all day. It is actually about being out there in this day and age providing 21st nursing care. Thank you.